This is going to be a review for hematology. First, we're going to go into just generally the clotting cascades, a quick overview. Remember, the clotting cascade is basically what your liver does in making your clotting factors. There's different pathways that lead to the same road, the same end coagulation pathway, but with the two main roads where they combine, there's going to be two different medications, two different lab values, and then two different medications, two different antidotes. You don't need to know which factor turns into what other factor, so on and so forth. But it's good to know. Remember that there's the two different pathways that generally all end up in the same spot. So no matter which one you affect at the beginning, it's going to end the same result. And so if you're blocking one of those pathways, you will then limit your increased coagulation at the end, no matter what. So first, anticoagulant. First thing to remember is anticoagulants. They do not break up clots. They only prevent clot formation happening in the acute sense. They help your body then naturally break it down themselves. The anticoagulants themselves do not increase any thrombolytic properties at all. So warfarin, oral medication, has a longer onset, longer duration, longer half-life. It takes more time to have an effect. Okay, so with that, what this does is this blocks the breakdown of vitamin K into making our clotting factors in our liver. And so we're going to want to make sure we're anticoagulant. We assess for the risk of bleeding, right? That's the big thing. We're going to make sure we stop at least a week before surgery. We want to make sure we look for bruising, bleeding gums, assess for any bleeding complication, peptic ulcer disease, GERD, avoid other medications that increase risk of bleeding. Do not give to any patient who's had any sort of head trauma or surgical intervention in the last 3 months due to increased risk of bleeding complications. But generally speaking, you're going to want to assess the bleeding. So, the thing to check for bleeding is just, for internal bleeding, you're going to see a drop in your blood pressure. You'll be hypotensive, then the reflex tachycardia. So, if you see that, you can gather you might have bleeding somewhere in the body, internal hemorrhage that you don't want to avoid. Um, Otherwise, with warfarin, you want to assess the PT-INR, which should be 2 to 3. If it's less than 2, give more. If it's greater than 3, hold and call the provider. You generally do not want to give the antidote right away unless there is signs the patient is actively having huge hemorrhaging problems and bleeding problems. Because we gave the anticoagulant for a reason. Even if they are elevated, does not mean that they are actively having a problem. Are they at risk? Yes. Actively having a problem? No. So we're going to hold the provider and then go from there. So with warfarin, it's the only medication that we're going to talk about that has dietary restrictions. So we want to. Here's the trick here. Vitamin K. Um, if you are a patient who eats a lot of vitamin K, you want to keep it consistent. Generally speaking, the average patient does not eat and take a lot of foods that are high in vitamin K, foods that are high green leafy vegetables, and so on and so forth. And so therefore, we want to tell them we want to avoid the foods that are high in vitamin K. And so we want to make sure they have maintained a consistent vitamin K intake. If the vitamin K intake is fairly low, we want to maintain that. Okay, so we're going to want to make sure we avoid foods that are high in vitamin K. Heparin. Heparin is our acute acting, short duration anticoagulant. It can be given IV or sub-Q. Enoxaparin is a low molecular weight heparin that's given sub-Q only. It requires less dosing. It has longer duration. And so we're going to want to be aware of that. With enoxaparin is also air bubbles in the syringe. The air bubble in the syringe should not be expelled. We want to keep the air bubble in there. It helps make sure that all the medication gets expressed out of the needle. For this, generally, your risks are going to be the same as warfarin. All the bleeding risks I said before are going to be the same. The only thing now with heparin, on top of general risk bleedings of different lab value, different antidote, which I don't really talk about it, but the antidote for warfarin is vitamin K. I kind of realized I never actually said it. Um, so for heparin, we have different lab value, PTT or APTT. For us, we're going to look at the PTT 60 to 80 seconds. We're going to want to also assess platelet levels. It can lead to thrombocytopenia, thus further increasing your risk of bleeding. And then your antidote is going to be protamine sulfate. For anticoagulants and risk for bleeding medications, you want to make sure herbals you avoid are ginger, garlic, and ginkgo. You also want to make sure you avoid vitamin E in all anticoagulants, because vitamin E is going to be keeps us from bleeding for everything. Where vitamin K is the reversal for warfarin, vitamin E increases anticoagulation for anything. So, say you have a patient who has an acute clotting problem. You want to give them some sort of immediate and long-acting anticoagulation. We can do that by doing a warfarin to heparin bridge. So what we're going to do is we're going to give both at the same time. We're going to give heparin because heparin is going to anticoagulate acutely. Then we give the warfarin, which will anticoagulate better long-term. Heparin should not be used for long-term anticoagulant. It should be only used for the short-term. So if you want longer-term anticoagulation, warfarin is the way to go because it requires less injections, less risk of complications with the injection sites, and so on and so forth. So you give both, and then if the heparin is therapeutic, that's great. We want it therapeutic. And if the warfarin is subtherapeutic, we want to make sure we give more of the warfarin so the warfarin becomes therapeutic. So when the warfarin becomes therapeutic, we will stop the heparin and then maintain the warfarin. Any of our other anticoagulants that work with just anticoagulating our blood, they're fairly common. So Ditroban, Atroban, Hexaban, all the various bands out there. General rules apply. Risk of bleeding, assess risk of bleeding, avoid peptic ulcer disease, GERD, the bruising, bleeding gums. The reversal is going to be a little harder with these. We can reverse them with certain medications. It's a little harder to do. But in the grand scheme of things, we want to be aware that we're assessing all the exact same things for all the problems. And that kind of keeps it pretty straightforward. Antiplatelet aggregation, aspirin, Plavix, Clopidogrel, same rules apply. In case risk of bleeding, can affect the platelets. Make sure you're affecting the platelet count. Make sure you're looking at the platelet count, make sure it's not getting too low. Avoid any herbal remedies, your ginger, garlic, ginkgo, vitamin E, that will lead to the increased risk of bleeding complications. But yeah, otherwise it's fairly straightforward. From thrombolytics, these are going to be the ones that actually will end up with dissolving the clot they currently have. So before we give these, they'll end in ACE, tryptokinase, aptoplase, activase, tenecteplase, the whole enzyme. So if it's ends in an ACE, it's going to be, for this stats review for hematology, it's going to be a thrombolytic. Okay. So, what do you want to know beforehand? We want to, again, assess any sort of traumatic injury, surgery, head trauma in the last 3 months. If they do, we can't give these. There's too much of a risk of internal bleeding, cerebral hemorrhaging. The benefits don't outweigh the risk of this. The risk outweigh the benefits. It's going to be an issue. We don't want to give it. If they had a stroke, we can do quickly check the blood sugar. Blood sugar is all you do when you have someone with a stroke. It's very easy, quick, rule out, because hypoglycemia can mimic the effects of stroke-like symptoms. That's what we want to do is we are going to want to assess for head CT. Make sure it's not ischemic versus hemorrhagic. If it's ischemic, we can give a thrombolytic. If it's hemorrhagic, we cannot give. A thrombolytic, so assess the underlying cause of the stroke itself. If we are going to give it for any reason, PE, DVT, MI, we want to make sure we do all invasive procedures beforehand, and we cannot do anything invasive 24 hours afterwards. Because with thrombolytic, we're not only dissolving clots they actively have, we're also going to prevent further clot formation for about a 24-hour period. And so we want to make sure we do anything invasive beforehand, because if we don't, we're going to have issues like all of a sudden the IV site is now oozing blood, blood's leaking out of any other central line, whatever. Now it's going to be a risk of, hey, something's not going well here, we need to stop and figure out what's happening. With thrombolytics, you will expect a high PTT, APTT, high PT-INR. Because as I said, now we are acutely dissolving and acutely stopping any clot formation. So we would therefore expect there to be high anticoagulation lab levels. Hemostatics, aminocholic acid. This is going to help promote clot formation. So we want to make sure, can this patient, do they have any history of bad clot formation, PE, DVT, MI, stroke? Do they have any large bodily trauma that can lead to small microclots flowing around that will then enlarge to larger clots? History of GAC. We want to make sure we count and assess for the bad clot formation with hemostatics. But that's that. So, biological hemopoietic growth factors, I'll put it that way. These are going to help grow your blood cells. I'm going to do apolivecan first. This one's going to be for your platelets. So apolivecan, we want to make sure we give this. Any of these we want to give after chemotherapy. Make sure we wait several hours, if not a day, before we give this, to help promote proper cell formation. Apolivecan is going to increase your platelet count. So we want to now assess your platelets. How is your underlying levels look? With this, there is some risk of some fluid retention. The fluid retention really won't lead to much risks of edema or hypertension, but it is there. Now, if we're talking about epoetin alpha, this is going to lead to high amounts of fluid retention and will lead to hypertension. Epoetin alpha is your erythropoietic growth factor for red blood cells. And so if we are increasing our red blood cell production, we are increasing the amount of solute in the solution, so that therefore when we are increasing the amount of cells, it's going to lead to more pull of fluid into the vessels to dilute the extra blood cells that they had, leading to the hypertension. And with that hypertension, have risks of MI, DVTs, and strokes. And we see bad clotting events, thromboembolic events of happening, because again, we've increased the blood pressure, we've increased the amount of cells flowing through the vessels, and increase the risk of something getting clotted off. So with this, we want to make sure we are assessing the blood pressure, assessing the H&H, make sure it's going up. We would expect that. Now for our white blood cell growth factors, they're going to end in stim, but it's the part before that that's important. So grastims or gramostims. Grastim is just going to be neutrophils, where sargromostim, there's an MO in there for the stem, that's going to be all white blood cells. So no matter what, it's going to increase white blood cells. The same rule as applies with the erythropoietic growth factors. It's going to increase the risk of fluid retention, hypertension, issues like that. So we want to be aware that we're assessing those problems, assessing the increased risk of thromboembolic events. But with the white blood cell growth modifiers, it's also a risk of causing thrombocytopenia for the grastims, and then for all of them, it's going to be an increased risk of bone pain. Because now we're increasing white blood cell production. White blood cells are larger cells. They get made in the bone marrow. They get stuck in the bone, long bones, and they can increase pressure inside the bone. Exerting that pressure on the bone is going to lead to pain. And so now we also want to be aware of that you're increasing the white blood cell response. So it's going to be increased risk now of causing inflammatory processes in the body, ARDS, pericardial effusions, things like that. So you want to make sure you're assessing those and ruling them out. Supplements, phenylcobalamin is going to be for patients with chronic ascites. It's going to be for pernicious anemia. I'll make sure we give these injections as appropriate to help increase the red blood cell production. Folic acid is going to help with your red blood cell production, and then iron obviously is needed for red blood cell production. But if you're giving iron, especially oral, you want to make sure you are assessing for those black tarry stools. Black tarry stools, this is not a GI bleed. It is just the excessive iron that we do not absorb. It's going to be excreted through the GI tract, leading to the black tarry stools, lead to constipation, increase your fluids and fiber. Avoid giving it with calcium, give with vitamin C. So, blood products. At any time, you're going to want to assess proper ABO, RH factor for the proper blood product. You want to give the patient what they need. They need red blood cells. ATH is low, give them packed red blood cells. If they need clotting factors, give them fresh frozen plasma. If they're losing platelets, give them platelets. Give them what they need. Okay. With your blood products, there's going to be a risk of same-fusion reactions. The biggest reaction is going to be a hemolytic reaction. If they have a hemolytic reaction, what you want to do, you're going to want to stop the infusion of the blood products. You want to maintain the patent IV, give them a fluid bolus, help dilute the blood that is wrong, assess for hypertension, tachycardia, and the lower flank pain. That's going to be a sign of hemolytic. Hemolytic is basically you gave the wrong blood type to the patient. Now the patient's body has lysed those blood cells in the hemolytic reaction. Febrile reaction, you just want to make sure that they're going to start spiking a fever, which we're just going to give acetaminophen. If they have mild allergic reaction, just give diphenhydramine for a mild one. If they have anaphylactic reaction, give epinephrine. Circulatory overload is going to happen if you're giving multiple blood products over a short period of time. So giving them a lot of blood volume is going to be hypertensive, show signs of jugular vein distension, fluid volume overload. Give diuretics, pull off the excess fluid, excess water, leaving the extra cells behind that you want them to take. Septic reaction is not going to happen acutely. It's going to happen over time, where generally if the blood product, which should be hung and infused in 4 hours, the blood tubing should be exchanged every 4 hours. If we did not do that, the blood sat along too long, infused too slowly, the line kept getting used, there's also biofilm going in the tubing and the bags, leading to septic reaction long term, which just be general signs of sepsis, and treat that normally with normal sepsis. And this concludes our heme review.